and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Improving Access to HIV/AIDS Care in the Rural South, Alleviating Structural Barriers Using Telemedicine. I am Rainey Campbell with the Southern AIDS Coalition. Just to give you a little background on the Southern AIDS Coalition, SAC was formed in 2001 and is a membership organization comprised of a unique partnership of government representatives, community-based organizations, people living with HIV disease, and business entities. SAC was born from the burgeoning numbers of people in the southern United States with HIV infection rates much higher than the rest of the U.S. population, particularly for newly diagnosed cases. While the southern states represent approximately 37% of the U.S. population, they represent over half of new HIV infections in the U.S. Federal funds do not meet the needs of those living with HIV in the South and are not equally distributed across the country. The disparate impact of this epidemic on Southern citizens, especially within communities of color, must be addressed. The Southern AIDS Coalition works to provide Southerners with the opportunity to receive adequate HIV/AIDS prevention information, treatment, support services, and housing. A regional membership organization headquartered in Birmingham, Alabama, SAC has a national reputation for leading advocacy and effecting policy change that improves the quality of life for those living with HIV in the South. The Southern AIDS Coalition would like to thank our generous sponsor, Janssen Therapeutics, and our partner, AIDS United, through the Southern Reach Initiative. Without their support, this broadcast would not be possible. We encourage you to visit our website, southernaidscoalition.org, to download the slides from today's webcast, to join our listserv, and make use of the many resources found on our site, including the 2012 Southern States Manifesto. We have a very distinguished panel for you today. Our presenters today are Sandra Percival. Sandra is the Program Director for Telemedicine and Distance Learning Initiatives at Medical AIDS Outreach of Alabama. Sandra came to MAO after more than 9 years in the U.S. Air Force, where she served as Public Affairs Specialist and Knowledge Operations Manager. Her background with the Air Force prepared her to step into a rapidly expanding program at MAO of modern technology to transcend the barriers of care for people living with HIV in rural areas. Dr. Prashant Bhatt will be next. Dr. Bhatt has been a physician with Medical AIDS Outreach of Alabama since 2010. He's been directly involved with the Alabama eHealth Initiative since the summer of 2012. Prior to that, Dr. Bhatt was a resident physician at Baptist Medical Center in Montgomery from 2007 to 2010. He received a master's in public health focusing on epidemiology and health disparities from the University of North Texas Health Science Center at Fort Worth in 2006 and was a physician with community and corporate health care centers in India between 2000 and 2003. Dr. Bhatt attended medical school at Manipal University in India. His interests include researching health disparities, looking for community-based solutions for global health initiatives, impact of chronic diseases on public health, expanding access to health care, HIV and its effects on medico-social fabric and chronic disease management. Mary Elizabeth Marr. Mary Elizabeth has been working in the AIDS arena since 1992, starting out as a health educator for the American Red Cross. While serving as health educator, Mary Elizabeth was awarded Educator of the Year by the AIDS Task Force of Alabama in 1998. Also during that time, she served on the board of directors for AIDS Action Coalition. Mary Elizabeth has served on numerous local, statewide, and national committees in a variety of capacities, including Chairman of the Statewide AIDS Network for the American Red Cross, Chairman of the AIDS Service Organization Network of Alabama for the past 3 years, member of the Federal AIDS Policy Partnership, AIDS United's Public Policy Committee, and recently completed Johnson & Johnson's Healthcare Executive Program at UCLA. Since becoming the director of AIDS Action Coalition in 1999, Mary Elizabeth has grown the organization from a $500,000 yearly budget to $3.2 million annually, vastly expanded clinical care, established a CDC grant targeting African Americans, increased testing, recently added housing and substance abuse and mental health funding. Mary Elizabeth serves as a local, statewide, and national advocate for people living with HIV and AIDS in North Alabama. She has a degree in education from Nicholls State University in Thibodaux, Louisiana. So you may ask, what is telemedicine and why do we at the Southern AIDS Coalition feel it is important to share this information with you today? As most of you are probably familiar with, the release of the HIV Treatment Cascade in March 2011 revealed that nearly 3 out of 4 people living with HIV in the U.S. have failed to successfully navigate the HIV continuum of care. HIV service providers and stakeholders must examine the critical questions of why those tested and diagnosed with HIV many times are not linked and retained in care, and what barriers can be eliminated to make sure that HIV-positive individuals are getting the life-saving treatment that they need. The Access to Care Initiative Telemedicine sets to address this issue in the rural South. In the South, 2/3 of people living with HIV reside in rural areas. Research shows that rural persons living with HIV disease, as compared to their urban counterparts, suffer significantly higher problem severity ratings for several barriers, including the need to travel long distances to medical facilities and personnel, a shortage of adequately trained medical and mental health professionals, a lack of personal or public transportation, and community stigma toward people living with HIV. The Telemedicine Project in Alabama is able to provide a solution for all of these barriers. This project is one of a small cohort of sites around the country. It actualizes the potential of technology to dissolve the structural barriers to care presented by poverty, stigma, and simple scarcity of resources. It uses telemedicine for the provision of high-quality HIV/AIDS care, effectively dissolving the barriers to optimal engagement faced by rural consumers throughout the Deep South. Since it is not always feasible for service providers to travel to learn about a new program, SAC's goal is to bring the information to you. Today, we will meet the following objectives: discuss the benefits of telemedicine and how it can improve HIV treatment and care, provide concrete, realistic information necessary to implement a telemedicine program, and share information and coordinate stakeholders to improve HIV treatment, care, and prevention in the South. Here's what's ahead for today's program. Sandra will give an overview of the telemedicine process and why it works, including logistics and measurable outcomes. Dr. Batt will share the doctor-patient experience and how a medical encounter is conducted via telemedicine. And then Mary Elizabeth will provide perspective on how it has allowed her organization to expand its linkage, retention, and overall access to care. We will have time at the end of the presentation for questions and answers. The 800 number to call and email address to send in questions are on the screen now and will appear again later in the program. Sandra, let's start with you. Tell us a little bit about MAO and the Telemedicine Initiative.
Sure. Let's start with MAO's mission statement. We are a private, nonprofit, community-based AIDS service organization that was established in 1987. We've actually transitioned from a fully volunteer education and service organization to a full-time primary care facility. Our clients can access both medical and social services in Montgomery and Dothan locations and each of the rural clinics that MAO operates. MAO also provides HIV education and testing, mental health counseling to patients and their family members. We also provide community prevention education, quality services, and compassionate care to all of those infected with and or affected by HIV and AIDS. Our services include social services, medical treatment, medication assistance, pharmacist consultations, mental health counseling, patient education, prevention education, of course HIV testing, And we also have food bank services, which have been a huge help in getting people and getting those patients to come to their appointments. What we try to do is we incorporate a whole life approach to treating HIV. What we found is if we can help these patients with the barriers to care, then they're more likely to be retained in care. And providing food bank services, social services, and translation and things like that has been a huge help in continuing to keep people in care. Just to give you some broad information of what telemedicine is, it's basically a video chat with a doctor. So if you've ever used Skype or any kind of video teleconference equipment, that is exactly what this is. What we do is we put a patient in a clinic site with a nurse or a practitioner, and they're able to then communicate with the specialist through the video screen. We use a high-definition camera and video screen as well as Bluetooth medical equipment. The Bluetooth medical equipment is really cutting edge. What we have is a stethoscope that our nurse practitioner can use in the room with the patient. And everything that nurse practitioner sees and hears, the doctor in the other room, be it across the state or across the country, can see and hear the exact same thing through their stethoscope and on the screen in front of them. It's actually 100% secure, so it's HIPAA compliant. Like we said earlier, I come from the Air Force, and the DoD's standard for encryption is 64-bit, but we use 128-bit, so we've doubled that. So it's 100% secure. And what this does is it transcends a lot of the barriers to care that people living with HIV and AIDS face, especially in Alabama and some of our rural areas. Those barriers are the increasing number of HIV diagnoses. We are dealing with an epidemic. We have a lot of patients, more and more diagnosed every year, and I'll get to that in a second. Our poverty rates in Alabama, which leads to a lack of transportation, health professional shortage areas, and stigma. And to give you guys a big picture of the stigma, even those of us who work in the HIV/AIDS clinics, we see a lot of stigma, so I can't imagine what our patients see. I'm relatively new to MAO, and when I told someone where I was working, they said, "Wow, I'm going to go sit outside across the street and watch who goes in there so I can laugh at them because they have AIDS." So we have to learn how to counter that so that these individuals don't have to feel embarrassed to go into a clinic to get care, because that's one of the biggest barriers that these people face. At the end of 2012, we had almost 12,000 individuals known to be living with HIV in the state of Alabama. Of those, only 41% had progressed to AIDS. I say only because what we're seeing is a flop in the proportions of HIV to AIDS diagnosis. We're seeing less and less progress to AIDS because they are linked into care and retained in care. The CDC estimates that about 18% of individuals who do have HIV are unaware of their status, which would mean that in the state of Alabama, we probably have 2,000 to 4,000 additional undiagnosed cases of HIV. And this is just a map that I pulled down from the ADPH report for 2012. You can see the darker areas are the higher concentrations of HIV diagnosis. Poverty rates. In Alabama, out of our 67 counties, 46 of those have poverty rates higher than the national average. 23 counties have poverty rates that are above 20%, and 5 have poverty rates above 30%. Wilcox County has the highest poverty rate, with 39% of the population living below the poverty line. And according to the U.S. Census Bureau, the average household income in Alabama is less than 200% of the federal poverty definition. What that means is that most of our patients in those rural areas do not have their own personal means of transportation. If they don't own a car, in the state of Alabama, we have a severe shortage of mass transit. So if those individuals can't get a friend to drive them to their appointment, then they're not they're unable to go. And asking someone to drive you to an HIV/AIDS clinic is a very, very hard thing to do, and a lot of people don't want to do that because they don't want to disclose their status. 17% of Alabama's residents live below the national poverty line. So here's a big picture just to give you a graphic of a representation of where that poverty is. And these are the areas where we're seeing an increased diagnosis. If we were to put those two maps side by side, the higher rates of diagnosis are in these poverty areas. With that, we also have health professional shortage areas. 62 counties are health professional shortage areas in Alabama. There are only 57 infectious disease doctors and 3 American Academy of HIV Medicine credentialed physicians, which would give you about 1 expert per 80,000 Alabamians, or 1 per 250 diagnosed cases of HIV and AIDS. If all of those doctors were actually practicing full-time HIV medicine, their patient load would be about 250, but we don't have all of those doctors practicing full-time HIV medicine, so their patient load is a lot higher, and we're seeing more and more doctors who are possibly overworked, and the patients are underserviced, quite frankly. And a map of the health professional shortage areas. You see the blue areas, the darker blue. The entire counties are health professional shortage areas. And the light blue are partial health professional shortage areas. So we've got almost the entire state in this predicament. With telemedicine, Alabama eHealth has placed clinics in Selma, Sipsey, and Florence, with corresponding hubs in Montgomery, Tuscaloosa, and Huntsville. What we've done is we've covered a broad area of geographic locations so that these individuals who are in those poverty areas who don't have access to a specialist can now go to those telemedicine clinics and get care right there in their neighborhood, whereas before the doctors would have had to travel, or those patients would have had to ask someone to drive them an hour or further away from their home. And we've seen a retention rate of 92%. That's 92% of all individuals that we've enrolled in the telemedicine program with MAO are still retained in care. We also have plans to expand to Troy, Clayton, and the Wiregrass area with a hub in Dothan. Dothan's already up and running, but we're in the process of making that into a hub area for those smaller satellite clinics that we plan to open. So it's just a map of all of our telemedicine locations and how far we've been able to reach. Eventually, what we want to do long-term is create a statewide telemedicine network where individuals in any county in Alabama can go into possibly their county health department location. And if we could do that, if we could get a telemedicine suite in every county health department location, that would put care right there in everyone's neighborhood so that they don't have to travel. And not only that, they won't have to deal with the stigma. The stigma is a big issue because right now we're sending people to HIV/AIDS clinics that are specifically designated for HIV care. And if we could send them to something that's not labeled specifically for HIV care, then those individuals could go into a clinic without automatically disclosing their status just for walking into the building.
Thank you, Sandra, for giving us an overview of the telemedicine and project in Alabama and the HIV/AIDS epidemic in Alabama. And Dr. Batt, you work with Sandra at MAO. Could you share with us some of your experiences as a physician?
Absolutely, Rainey. Well, my name is Prashant Batt. I'm a physician with Montgomery Medical AIDS Outreach now. First of all, I would like to thank the Alabama Department of Public Health as well as the Southern AIDS Coalition for giving us this opportunity. And Rainey and Dane, thank you very much. And welcome to Montgomery, Mimar.
Thank you.
Yes. We will discuss a few thoughts about how a telemedicine encounter is conducted and how it is different from an in-face or in-person encounter, face-to-face encounter. And we will compare and contrast. And we will also discuss a few things about some of the success stories that we've had, some of the challenges we've had, and how anyone with an interest and resources can implement and replicate our success in telemedicine. The idea of telemedicine started in 2009 in Montgomery AIDS Outreach, what was then Montgomery AIDS Outreach, which is now Medical AIDS Outreach of Alabama. Thanks to our CEO, Mike Murphy, and Mimar. It started as a random thought after observing telepsychiatry, right, Mimar?
Yes, yes.
Once the telepsychiatry model, which was all pervasive and which was successfully being implemented, we thought how it could be utilized in executing and delivering medical care to our patient population.
Our original thought, Michael's and my original thought was through the AIDS United grant, it was an access to care grant.
Correct.
And we wanted to see if we could somehow increase access throughout all of Alabama. So this seemed like a natural fit.
Yes. Absolutely, absolutely. The telemedicine network, which was just a thought in 2009, came into fruition in 2011. The planning phase took a little longer, but the executing phase, which we implemented in early 2012. So the past 18 or so months, we have this telemedicine clinic going on. We are covering 2/3 of Alabama with our telemedicine network. We have 3 permanent sites in Montgomery, Huntsville, and Tuscaloosa, and we started off with 3 satellite sites. So the initial idea was to have a hub and spoke model. So the hub is a specialist, and the spoke is where the rural clinic is. Now it has evolved into a situation wherein the spokes are talking to each other because we have the talent and resources available in the spoke sites as well. Well, let's talk about what happens in a patient visit. I hope everybody has had at least a few patient visits, especially as children. So a patient visit comprises of a distinct set of events. The patient comes in, the nurse asks the patient if there is any specific complaint or a situation that needs to be addressed on that particular day, in addition to the routine follow-up or the visit. And the nurse also asks if there had been any medical events that happened since the last visit. And she or he proceeds to reconcile all the medications that the patient will be taking or is taking on that particular day or in the recent past. And then the patient's vitals are checked, and then the medical doctor or the provider or the nurse practitioner or physician assistant will be notified of the patient in the room. And then the provider walks into the room, talks to the patient, and then the interaction with the patient of a provider is also a set of events. So there will be an interview with the patient, and then there will be a discussion of the tests, and we will review the vitals, and we will review the, like I said, the labs and tests and such kind of things. And then there is examination, and then there is discussion of what we found, and a kind of grouping together of the data available. And then we come up with a plan which is agreeable to the patient. We also make sure that the patient verbalizes understanding. So in this one, as you heard Sandy say about telemedicine being a video chat, it is real time and it's high definition. So the nurse is present with the patient. So everything that the nurse does with the patient, being be it reviewing the chief complaint, what we call in medical terminology, or reconciling the medications, or checking the vitals, or checking with the patient about what happened in the interim, these happen. In the physician part of the encounter, interview with the patient is through the high definition audio video equipment. Examination comprises of inspection, auscultation, and palpation. For whatever it means that we have kind of sort of forgotten about percussion. We don't use that percussion very much because of the advent of the resources that we have. So interview the patient, the inspection part, sorry about that, inspection part is seen through the high definition video. Auscultation is done by the Bluetooth stethoscope, which is really cool in that my nurse actually puts the stethoscope, the chest piece on the patient, and I can actually, sitting 100 miles away, can listen to. This is our receptionist in Dothan, if you see the picture, and that's me sitting there, and I will access the charts through the EMR. So I will review the test results and such things with the patient in real time through the high-def video, and I will also see what is going on, what the patient is seeing from that end through that small little thing at 2 o'clock position in the high-def TV there. So we also have a Bluetooth ENT scope wherein we can check the ear, nose, and throat of the patient, and a dermoscope wherein we actually can take the pictures of the skin lesions or moles or whatnot, and we can actually tag it to the EMR. And we will discuss the results with the patient, and we will come up with a plan about do we continue the medications, do we talk about the diet and exercise and a complete plan to keep the patient healthy, and if there is any need for prescriptions, we will e-scribe it through the computer to the pharmacy of patient's choice. So this is what an encounter looks like. So the only handicap is the touch. Everything else is actually included in a patient encounter. The patient being in the room, the pressure, the temperature, the humidity of the patient's skin, that's the only thing that is not covered. So the limitations of telemedicine would be that, yes, of course, we are not able to do a pap smear. We are not able to deliver babies to telemedicine, yes. But for routine visits, especially in HIV and AIDS, telemedicine works as good as an in-person visit. Imar, do you have any?
Well, it's almost, in many cases, it really enhances the appointment because of the fact that the client, again, doesn't have to leave their community, and which I'm going to talk about in a little while. Some of our clients either have to travel an hour and a half, 2 hours, maybe just for a laboratory appointment where they're just finding out their lab values. Now they can do that through telemedicine, and it's much quicker and much less painful from the standpoint of having to travel such a long distance.
Yes, absolutely, Mimar, absolutely. We talked about the provider and patient interaction on telemedicine. Why don't we sweeten the deal? We not only take care of patients' health conditions, we also have a clinical pharmacist on staff who teaches and educates and counsels patients on be it diabetes education, be it tobacco cessation, be it HIV medication adherence, be it diet needed to control their cholesterol, be it the diet or exercise needed to control their high blood pressure. So, and things that we could do on a day-to-day basis with respect to nutrition. We also have a clinical mental health counselor based in Dothan. You remember me telling you that the hubs have, the spokes have started to speak to each other. Dothan is and was a spoke site of Montgomery. Well, our Dothan site has a mental health counselor. We don't have one in be it Montgomery, be it Selma, be it Clayton or Troy. So we utilized that expertise in discharging and executing mental health counseling to our patients. We also have social workers interacting with each other of different sites to benefit the patient, to expand the plans. So overall, the telemedicine not only is for physician and patient, and Sandy, I have to say that we deliver direct to patient care. So the nurse practitioners do take care of patients, and the physician oversight is about 10% at least. So we do not have a nurse practitioner on the other end of the telemedicine. We actually have a nurse and the patient. So because the patient will be interacting with us directly. So that's why telemedicine is a viable option, in that the patients do not have to travel so long to come and see me in person. Now, I will also tell you what used to happen before 2012, before we implemented telemedicine. I'll give you an example of our Selma clinic, which is a rural clinic which is situated about an hour west of Montgomery. So we did not have electronic medical records then. So what we would do is, every week, one day, that was a Wednesday morning at 8 o'clock, we would pile on all the charts in the van, and we would have a phlebotomist, and we would have a receptionist and a nurse and a social worker along with a provider start the van, drive 1 hour west. It would take about an hour, and coming back is an hour. So in an 8-hour work day, if you were to take away about an hour for lunch, we would effectively see the patients for about 4.5, 5 hours or so. Now, let's talk about telemedicine then. So with the telemedicine, our patients in Selma like to come in at around 9 o'clock because our collaborative partner there prefers that timing. So I see patients from 8 o'clock till 9 o'clock in Montgomery, and from 9 o'clock till about 1 o'clock, I see the patients in Selma through telemedicine. That's about 4 hours. And I continue to see patients from 1 o'clock till 5 o'clock or 4:30 in Montgomery. So, and I repeat this twice a week. So I'm effectively giving just 8 hours of care to the patients that we used to do in the past also, but we have doubled, literally doubled the hours of access. So isn't that a beauty?
It is. It's a beautiful thing.
Hardware. How would anybody replicate a telemedicine clinic that we're running and succeed? Hardware is extremely important in that we have to have the right tools. The number one barrier for us to implement telemedicine in Alabama was not the expertise, was not the providers, was not the funding. It was actually the lack of internet. It's astounding that we could not actually get a T1 line, which telemedicine with this degree of encryption to be HIPAA compliant needs the speed what we call as 1 meg duplex, which is 1 megabytes up and 1 megabytes down. So T1 line, which is 1.5 megabits, which will be useful. So we did not have a T1 line until yesterday. We actually were successful in getting that line in our Clayton clinic. So we can now say that in the next month we will be implementing and executing the Clayton telemedicine clinic also. So we use Polycom machines. I am personally pleased by using that. I'm not being paid by Polycom to say that their equipment is good. We use Polycom HDX 7000. It's the name of the instrument that we use, which has the codecs which will ramble up the signals, audio-visual signals from my end or the patient's end, and transmit it through the internet and unscramble it on the other end. So it's completely encrypted, so nobody can hack it or get the patient information. For a couple rural sites, we have been using Polycom HDX 4500, which is one model previous, which is portable also. We use for stethoscope, we use 3M Telestat. Littman, everybody uses Littman. Littman's electronic stethoscope, which is also Bluetooth enabled. So 3M Telestat program. We use for our ENT scope and dermoscope a Total Exam 3D. My IT director has promised me that the Total Exam 3D, 3 HD, will be available to me within the next month. So I'm going to say that. Actually, I'm using Total Exam 2 right now. And T1 internet line. And the costs. So the Polycom machine costs about $9,000 on one end. So double it, it's about $18,000. The stethoscope costs about $500. The program is about $100 per user. So we will have 2 users, one on the hub site and the one on the spoke site, and as needed by other clinics. The total exam 3 HD costs about $5,000. So this is very affordable. Telemedicine as a solution is very affordable. And we will hear some good news about telemedicine later this year when AIDS United releases the effectivity data, how useful telemedicine is. In short, I don't want to break that surprise, but in medicine we use this terminology called numbers needed to treat, which is if we were to do an intervention, a medication, how many people have to treat to prevent one event? So for telemedicine to prevent the progression of HIV or getting the patients in care, it's astounding. The numbers are astounding. So please wait for that data to be released later this year by Dr. Hargrove. Yes, Holgrave. Yes. So how telemedicine decreases healthcare disparities, and how does it increase health equity? You saw earlier that 62 out of 67 counties in Alabama are physician shortage areas. 59 counties out of 67 counties are rural areas. We are looking at astounding barriers that the rest of the United States cannot even begin to imagine, I feel sometimes. Be it the transportation, be it the stigma. Even in 2013, I have my patients telling me that their family, if they were to know about their HIV status, would make them use a separate bathroom, would give them plastic forks and spoons. This is such a shame, and it should not be ever pardoned, because everybody needs that extra support, especially true in people with HIV. Our goal is to make our patients believe that and make that HIV is actually a very small part of their life. It should never be the be-all and one-all part. So they can go about taking care of whatever they enjoy and do about their business. So this telemedicine actually fills in the gap in that access to care, the rural health. People will have access to health care. The grand vision is that if we were to connect all HIV clinics in the state of Alabama, we can have a wonderful patient-centered medical home if there is an electronic medical record interoperability and such kind of things. Well, there is a lot of logistics to that one, but we can have a wonderful patient-centered medical home for everybody with HIV in the state of Alabama, and this is a doable thing. So let me tell you a couple stories to see, for me to kind of say how telemedicine has impacted my patients in particular. Well, let's rewind the date to 2012. I have this wonderful lady as a patient who is about in her early 30s. Because of HIPAA laws, and because of just the decency, I will never inform who that is and such things. But I know she would want me to tell though. She has history of AIDS, HIV and AIDS since 2005. She was in care, but she dropped out of care. This was in 2009. In 2010, she came back to care. She was 87 pounds then. Her CD4 was less than 1. Less than 1 is non-existent CD4. The normal CD4 level is 500 or above. Anything less than 200 we call as AIDS. AIDS is acquired immune deficiency syndrome. So HIV is a virus, that's the infection, and if there is an immune deficiency that is acquired, that's called AIDS. So either CD4 falls less than 200 or one of the 23 criteria that CDC has put forward if the patient were to get it. This was because of non-adherence. Well, to the point that her own family was thinking that she was faking it because she was not taking care of her daughter. Well, the daughter is negative. And she was incidentally diagnosed when she was pregnant with her first daughter. So she got into care. She did wonderfully well. She started medications. She's on what we call a salvage regimen. That means as of today, unless new medications come out, she does not have any other choice of medications if she were to lose this regimen. And for HIV medications to work, we need a near 100% adherence. Patients will have to take medications every single day. Every single day. And if the patients do not take medications every single day, this HIV, which is a living organism, will adapt and create mutations to withstand these medications and become resistant to these medications. So my patient, my lady, was on salvage regimen. And she was doing wonderful. Her CD4 actually increased to over 500. And she meets this wonderful man in my waiting room, who is also my patient. And they get married. And they're pregnant. And everything is fine. And she gives birth to a beautiful baby girl. And unfortunately goes into postpartum depression. And the husband also goes into depression, that they both become non-adherent. At least one of them reverts back to substance use. And both of them stop taking their medications and actually start taking medications intermittently, which is extremely dangerous in HIV. So the follow-up visit, I saw the patient. And she was distraught. And she did confide in me that she was not taking her medications right. And as a provider, I was worried because this is a salvage regimen and she deserves a right to live her life fully. So immediately, within 24 hours, we contacted our counselor who is in Dothan, which is 2.5 hours away. For me, it's 2.5 hours. For some, for example, Mike, it's probably 1.5 hours away. Our counselor could talk to her. We started her on medications. She went through the counseling sessions. She started taking her medications back, and she is undetectable again. Without telemedicine, it was probably, and she is uninsured. So it was probably impossible to get her into the care of a counselor so quickly. And we could have seen some pretty bad outcomes. So now the patient is doing wonderful. She's undetectable. Actually, she has started her master's program. She is starting her master's program this fall.
Yes.
Yes. Have you had some experiences like that, Mimar?
We have. We've had some great experiences where clients have needed extra help. We also use our telemedicine for translation services, which is a big help because we have a translator in Huntsville, but we don't have one in Florence. And we've also used our telemedicine for psychiatry. Yes. And I'm going to talk a little bit about our substance abuse program.
Absolutely. Yes. So I do feel this telemedicine is a wonderful adjunct to healthcare in Alabama. People might ask, will it replace physicians? Will it replace the in-person, will it replace the physician's touch? Well, it will not replace it. It will not replace it. It's an adjunct. Like I said,
there's job security for you. You're not going to be replaced completely with telemedicine.
Well, the last time somebody told me that, I actually was a little prissy about it and actually told them that I'm too good to be fired.
Oh,
okay. Anyway, let's get back to so telemedicine is a wonderful adjunct to the routine healthcare, especially true in healthcare shortage areas wherein our patients do not have access to care, access to healthcare. Also, it's true that when patients come in, or any person who would come in the same community, when it's not labeled an HIV clinic. For example, in Selma, we have a wonderful collaboration going on with UAB Family Medicine Residency Program. And I also forgot to say that we also train family medicine residents and medical students and pharmacy students and nursing students also, and they also get a hang of what telemedicine is and such things. So telemedicine is a wonderful, wonderful piece of equipment or a resource for routine care, for some of the acute care also. But if a patient were to come in with abdominal pain, we might not be able to do much because palpation is important. If we go back to what I said about examination part, we can do inspection wonderfully well. We can do auscultation beautifully. Only thing that's lacking is palpation. Well, the future is bright in that also. There are, I've heard of tactile gloves that were in a remote area. The nurse can wear the glove, and it's not really in practice. It's all in research areas right now. The other wearer can actually feel what's going on the other side, hundreds of miles away. Isn't that cool? So we are actually harnessing technology to improve healthcare access. That's all we are doing at the end of the day. And by that, we are increasing the quality of life of our patients. Well, thank you, Rainey.
Thank you, Dr. Batt. I think that was really well said. And just to sort of piggyback on something you just mentioned, even if you can't do that palliative care where they need to come in, at least you're having that first contact with them through telemedicine, and you can say, you really should come see us at the clinic in Montgomery.
Absolutely.
So I think it's still a first point of contact, even if you do need to bring them in further.
Absolutely. And I have to say that one. In the past year, in Selma, we have about 150 patients, which might not seem like a lot of patients in general medical practice, but for HIV, it's a decent-sized population. And with all encounters, including pharmacy visits and pharmacist visits and counseling visits and such things, we've actually had about 500 encounters and patient-provided visits. And I have to still find the first person who did not like it. I still have to find it. I'm looking.
The patients are very, very satisfied with the service. We also in Huntsville don't hear any complaints on the patient level.
Yes.
Well, thank you for sharing a little bit about the doctor-patient experience, and we're going to take a brief 10-minute break, and when we return, Mary Elizabeth is going to present on the director's perspective of telemedicine. And please remember that you can call and email questions at the end, and we will have a discussion and Q&A session. So we'll see you after a 10-minute break.
Thank you, Ryan.
You said you didn't have anything to talk about.
Welcome back. During the first part of the program, we heard about the work at MAO, and now let's talk about the project in North Alabama. Mary Elizabeth, will you share with us some of the telemedicine experience from an administrative perspective?
Absolutely. Thank you, Rainey. And I want to echo Dr. Batt in thanking ADPH and the Southern AIDS Coalition for helping to let us publicize this on a national level. I don't know if there's anybody out there in TV land, but if so, we'll hear from people in a short while. So back in 2009, Mike and I were looking to write a grant to AIDS United for access to care, to try to bring our state a little bit more together. And so we looked at telemedicine as something that was being done, especially in the Black Belt with psychiatry. And we thought, well, why couldn't we link our clinics together and to try to build access out in our rural communities? So if you can visually, I don't have a state map up here, but if you can visually think about AIDS Action Coalition's service area, we are the top quarter of the state or so. We go from Mississippi to Georgia and Tennessee all the way down to Birmingham, all the way through Coleman to Birmingham. We have a a site in Huntsville, and then our second site is over in Florence, which is approximately an hour and a half away. Mostly 2 4-lane roads to get there, and I was looking at, number one, our clients didn't have great access out in our Florence clinic where we would go twice a month. We had a social worker out in that clinic 5 days a week, but as far as medical care, we could only be out there twice a month. And so I was looking at access to care and also that almighty uncompensated time that we spent with, again, as Dr. Bott talked about, sending out a phlebotomist, sending out a nurse, sending out a provider. And that's a lot of people to put on the road for an hour and a half one way when they're not seeing patients. So telemedicine seemed to be a really good idea to get that to happen, or to increase care. Not only were we not seeing patients during our travel time, but one of the other things is that we have our no-shows. And when you have a full day scheduled out there, but maybe a half of the clients don't show up, which of course we don't want to happen, but you know, things do happen. Then you have a whole group of providers that are sitting out in Florence with nothing to do, and again, that's very, very much uncompensated time. If that provider is sitting in Huntsville, they can see patients even if we have no-show patients in Florence. So that's really maximizing what we need to do for our clinicians. The expensive transportation costs were also daunting to think about. The fact that we do have a van, but you've got the cost of upkeep of the van, you've got the gasoline, you've got, and again, that uncompensated time. So we would have clients that may travel anywhere from 1 to 4 hours for a lab result appointment, which, you know, we don't do those kind of appointments over the phone because other things may come up in that appointment. But if you did have a client that just came for a lab result, that seems like a very big waste of time to travel 4 hours just for that appointment. We have an agency driver for clients who have trouble with their transportation, but if you can think about going from Huntsville all the way over to the Mississippi border, that may be 2 hours, 2+ hours, to pick a patient up, bring them all the way back to Huntsville. They sit for their appointment, then they go all the way back to Marion County or Red Bay, and then come all the way back to Huntsville. That driver is spending an 8 to 10 hour day to provide transportation for a small number of patients. Of course, in the HIV/AIDS world, we're going to do whatever we need to do to get people into care, but there needed to be a better way of doing business. So now with Florence being halfway between, at least we're reducing that time. And I'll talk a little bit about the additional services that we've got planned in the next couple of months that'll also take care of some of these transportation costs. So the increased access to care, the clients in the Florence satellite clinic, we went from 2 days a week to 2 days. I mean, we've gone from 2 days per week and versus the 2 days per month that we were doing, and those decreased travel costs. We're also seeing, I think it's just coming out of now having more access to care in Florence. In a 2-week period, I've been on the road a lot, but I think it was about 3 weeks ago I was out in Florence, and our social worker told me that she had seen 6 new or reestablished patients during a 2-week period in Florence. This is a tremendous increase. I think this is partially because clients are now realizing that they don't have to travel maybe all the way to Birmingham for their care or to up to Vanderbilt. That they can be seen for their HIV care right there in Florence. And so as the word gets out, I think we will see a tremendous increase in the number of clients that are being seen. So this works to linkage to care, which is what we are all trying to do in this country, is to try to identify people that are needing care, getting them into care with linkage to care, and then retaining them in care through having established partnerships in clinics and such. So some of our new services that we're providing in Florence is that we have begun using access to our psychiatrist, who is in Huntsville, to see our patients in Florence. And when I see, I'm talking about the virtual seeing patients through telemedicine. Dr. Archibald is very open to using telemedicine, and he sees it as again, that travel time between Huntsville and Florence, but being able to see more patients for our buck, so to speak. We are now also expanding our telemedicine equipment in Huntsville, between Huntsville and Florence, because we have secured a SAMHSA grant where we have been providing telemedicine IOP in Huntsville. We are now going to start an IOP in Florence. We are going to connect those IOPs with Polycom telemedicine equipment. And what that will do is that it will enhance the experience for the clients in Florence to be able to be part of a bigger group in Huntsville. What we would like to see is that the counselor would be the direct facilitator in Florence 1 day a week, and then in Huntsville 3 days a week, having a facilitator sit in on the group in Florence when they are not facilitating. This will, again, be able to enhance the experience and also expand what we're able to do in Florence. So besides outpatient ambulatory medical, we're doing case management, we're doing the psychiatry, we're expanding to our substance abuse and mental health, and also our translation services. So I think I told you that I had the smaller part of the presentation. I've tried to stretch you guys and talk slowly, but I think that, before we wait and see if we've got questions, I wanted to piggyback on something that Sandra had talked about with the stigma. We were talking at a statewide meeting yesterday. This isn't something that happened 5 years ago. This was something that just happened this spring, where one of our sister organizations, after an advocacy day down in Montgomery, where we were all wearing red T-shirts, they stopped at I'm not going to call out the name of the store, but they stopped at a store on 65 on the way home, and somebody asked them what their red T-shirts were all about, because it said "Stop AIDS" on the back of the T-shirt. And when the proprietor of the store, he heard about it, he asked them to leave, because he didn't want AIDS in his store, which is just bizarre. This is not 1988. This is 2014, 13. So stigma lives in Alabama.
And Mimar, I'm interested to know, you've heard me, I'm not from here originally, I'm from India, so I'm a transplant to Alabama. Why is the stigma present? What do you think? What are your thoughts about what is the basis of the stigma? Why are people so afraid of HIV?
Well, I think that it's because they don't perceive it to be something that is... I've got a summer cold that will not go away. I think that they perceive it as being a large city problem and not a rural problem. And so I think that's part of it.
I think the other part of that is just a lack of education. Quite simply, it's a lack of education. And if we can get to those rural areas and try to help educate people about HIV and AIDS, it is not the end of the world. All it takes is a pill, and you can reduce your transmission rate. So I think that if we could get to people and let them know that it's not something stigmatized that only affects one type of person. It's something that's increasing in rural areas, in the Deep South, in the Bible Belt. It's a real thing, and it's something that needs to be addressed and not completely ignored and shoved under the rug.
And I feel when you say lack of education, I believe that lack of education is not going to go away with just some scholarships. It's a lack of education of the sense of community, the lack of education in the resources, it's a lack of education of the disease process itself, or the lack of education which actually makes some people to behave differently towards certain sets of people.
Well, it's not only lack of education in all those areas that you talked about, Dr. Bott, but it's even lack of education of our providers, which I think we all see here in the Deep South and in Alabama specifically. And hopefully with telemedicine, we're also going to be able to, begin to educate our providers out in the community and out in the rural areas so that when they see something that they're not equipped to handle, that they can call either, they can go into either Huntsville or Tuscaloosa or Montgomery and help with some of that specialty care.
Absolutely, Mimar. And I am actually proud to say that we as MAO have been instrumental in training medical students and residents, like I said before. And it's kind of a sense of accomplishment when I see that when some of the young doctors or medical students come in first, and I'm seeing them through the telemedicine on the other side, and they're wearing gloves to touch my patients, and at the end of that 30 minutes or 20 minutes, whatever, they're so friendly with the patient, they give a hug to the patient then. So that I do believe that there is that lack of education among healthcare people exists.
I think so too. I think so too.
I think that's a really good point, that once you have telemedicine in place and once that technology has paid for itself, you can use it for so many other things, whether it's training for social workers or providers or just a number of different continuing educational opportunities.
Absolutely.
So that's a really great resource. This kind of just icing, that just sweetens the deal, as you said earlier, to having a telemedicine program.
We've even used our telemedicine equipment for board meetings. So because again, we've got board members that live in Florence, and through using telemedicine equipment, also when we have full staff meetings, so our staff that is in Florence, they don't have to travel to Huntsville, they can go ahead and stay in their community and still participate in our full staff meetings. So it just opens up so many things that you can do, increasing your capabilities of providing overall care for your clients.
Right.
Absolutely, yes. The Alabama eHealth Initiative, which comprises of 47 counties of 67, which includes Mimar's Huntsville as well as Deborah Tucker's Tuscaloosa, along with our Montgomery, Dothan, the medical aids outreach area. I have to say that we do get a non-conventional burden of HIV in that more than 50%, I've been told, of new infections happen in our catchment area. And if we could get our people with HIV into care, and if we were to get our people undetectable, the risk of transmission goes down. This is a huge public health benefit. The HPTN 052 study actually said that the risk of transmission, the transmissibility of the virus, goes down 96% in a person who is chronically undetectable. So when we get the patients in care, not only we are improving the patient's health care, but we're also improving the health of the community and preventing new infections.
Right, and that goes back to some of it's life-saving care, and on top of that, some of the cost-effectiveness data that you alluded to earlier. The official data hasn't been released, but anecdotally, we can say that if 0.24% of new infections are averted, then this technology is cost-effective. So it's a really amazing thing. Before we open up to questions from our live audience and to our online viewers, would you want to add anything else to the discussion as our panelist?
The only thing I'd like to add is that I think that another part, anecdotally, of what this has done is that it has brought our organizations much closer together. We realize that many of our barriers and challenges are the same, whether you're in Montgomery or you're up in Huntsville, and just the collaboration between our two organizations has been delightful.
Certainly. There's definitely strength in numbers and in communication and collaboration, for sure.
Absolutely, absolutely.
So thank all of you so much for your presentations. And now that includes the presentation portion of our webcast, we'd like to open it up for questions from the audience and from our online viewers. So please call in or email your questions.
Go ahead.
I do have a question. I'm curious, and I guess it's directed a lot to Mary Elizabeth and to Dr. Batt. The positives are very good. I'd also be interested to know what challenges you all found, because for people out there thinking about it, I know they're in the back of their mind, they're saying, okay, that sounds so nice, but what if? So if y'all don't mind, maybe share a little bit about some of the challenges you found, both as an administrator and also as a provider.
As a provider, I can say that the challenges would be to implement the resource, Mike. Like I said before, the biggest challenge that we faced was actually the areas without internet connection. And I believe thanks to cable TV, we are seeing less and less of those areas, but it is the truth. And second barrier, I think, is probably the lack of education among providers, be it providers or the nurses actually. Some people might think that the barrier could be the patient's comfort level. In my experience, it's not become actually. I was talking to Dr. Thomas earlier about how patients receive this as a technology. It's been very positive because our patients in West Alabama, where there is great food and pine trees, nothing else, and good people, are grateful and thankful to us. And we are thankful to them also. So it's a win-win situation, I think. So if the patient or a person who is getting the care is apprehensive about the technology, the number one apprehension would be, would it be broadcast for everybody else? Would anybody know this one? Because I am on TV. So before the person even gets into the suite, we actually tell them and reinforce the fact that this is 100% confidential and it's HIPAA compliant, and their data will not be seen by anybody, and the encryption that we use is top class.
I think our only barrier has been actually with the providers, not with the clients. Dr. Batt is very, very open to this as a new technology, but a few of our providers have been, they want to touch the patient. They want to have that human touch. So I think that's really been the largest barrier, Mike. Our clients have also been very, very receptive to it. And everybody's a little bit of a ham on television, I think. And also, you know, with younger people, this is, I mean, videoing is not anything unusual. But it is our providers that want to have that human touch that have seen it more as a barrier.
Sorry, Royanne.
I would ask Mary Elizabeth, have you as an administrator found any strategies to sort of get them to buy in
No,
to this?
no.
It's
I'm
just
just
that they're
saying
used
we're
to
going to
this.
do this. We're just going to do this.
I think people grow
No, I'm
accustomed
just
to the
being
status quo. And
I
sometimes when
think
something's new, it's hard.
When something is new, anytime we have any change, everybody, you know, people are all get uncomfortable with change, but as they see that this is really the wave of the future, this is not all that unusual in other parts of the country.
Right.
I think that they're growing more comfortable with it, and I think the more we do it, the more comfortable we become. Now, I will say, just as any new electronic device, there's also the issues. Oh my gosh, connectivity. You know, if we're doing everything quite right, and I remember back when we started using fax machines that I had to ask every time how to use it.
Can I
And
just say
you just
something
push
on
that button.
This is, like I said earlier, it is just like a Skype phone call. You know how you go into Skype and you can build your contact list. It took me 5 minutes, maybe less than that, to learn how to use the equipment, because we have this tiny little control panel. It's like a TV remote, and it has a dial pad on it, and a call button, and a hang up button, and a mute button. And you go in there and you can program all of your contacts. So we have at MAO, we've already programmed all of the offices, the hub sites, and the satellite clinics. And all we do is we press the green call button, press the arrow down to the contact we want to call, and press the call button again.
And the contacts that
So-
you're putting in are actually
The IP address.
Yeah.
IP
IP address.
addresses. So it is very easy, but again, when technology is new,
Now,
there's that little bit of uncomfortableness.
I'm really curious about that, Mimar, because I've known your providers and they're very receptive people. Really, they are.
I hope they're watching.
Teresa, a fantastic
Oh,
nurse practitioner. and
wonderful,
Dr. Lyden.
wonderful providers.
Now, how is the community reacting to that? How are your clients thinking about they have seen the benefits of telemedicine, when they do know that when the access could be vastly higher, how do they react to a small glitch called the provider dissatisfaction?
Well, I think that Teresa is probably not, she's going to kill me when I get back to the office, but I think she does not probably voice her wish that she could touch the patient. I think she probably handles it very well with the client. I think the benefits very much overweigh the challenges, for sure.
Which brings my next question actually to the panelists. How has your community, I can speak about Montgomery, how has North Alabama community walked the line with you in this endeavor?
Well, I think what we hear is, you're doing that here? Gosh, I didn't know that we were doing that here in Alabama. Those are the kinds of things that we hear. They're surprised that we've taken on this technology.
Fantastic, and I can vouch for Montgomery, and Sandy can resonate what I say, that the Central Alabama community, South Central Alabama community has been a huge, huge support and of assistance and of direction for us. In fact, when we got the grant, it was walking on the edge of sword, actually, that thin thing there, because we did get the money, but we had to match it. And it was a lot of money. And elsewhere in the country, people could match it in 1, 2, 3 months. And we were kind of going slowly with that one because of our geographical location or economic status or whatnot. But I am really proud to say that the South Central Alabama people, the community, actually got this one for us. We raised every single dollar that was needed to match the grant right on time because of the help of our people. And I'm extremely thankful to that one. And I also have to say that community in Montgomery in general, especially Junior League, has been with us for the past year or so. They are our food bank collaborators and the volunteers of Junior League. This is all voluntary work. They are not getting paid for this one. They come and assist in preparing the boxes or giving the foods to the patients. And Miss Ashley in the audience is actually a Junior League member.
That is very important for us to point out. This was a one-for-one match, and it was difficult. It wasn't the $50,000 that we had to match. It was actually $500,000 a year that had to be matched. And when we talked to our cohorts around the country, they could make those matches in the large metropolitan northern cities with 2 or 3 grants. And when they got our invoices, pages and pages and pages of $10 donations, they were very, very surprised at the amount of work that went into making up that total match. But I think it's been worth it.
Absolutely, yes, Mimar. Have you had any local collaborators? Because I have to say that the success of our telemedicine would not be present without our strategic partner, Selma Air. I have to say, Selma aids information and
Referral, I think.
Referral, yes. They've been very instrumental in providing transportation to our patients in West Alabama. They bring the patients to the telemedicine suite because what's the use of telemedicine if the patients not show up, right? So they provide housing and transportation and medication assistance and such.
Well, some of our, I'm taking this off the top of my head, but thinking about our financial collaborators, Compass Bank, several other banks were instrumental in Alabama. We also had the help of Huntsville Hospital Foundation. So they were people that really saw the benefit of what we were trying to do with telemedicine, and that's how we got those collaborations going.
And my quick question to Rainey, I know you are emceeing this panel, but Southern AIDS Coalition, what is Southern AIDS Coalition's interest in telemedicine?
Our interest is to share this information with stakeholders around the South. So we're a regional organization of 16 states in DC, and we've had the directors that are part of our organization in South Carolina and in North Carolina and other states ask about this program and want to come and see this program because they feel they need that in their state, and the epidemic is very similar in their state. And this is a way for us to bring the information to them. And we think that it's important and it's vital, and this is something that people need to hear about.
Thank you very much.
Do we have any other questions from the audience?
Audience questions? No, we have several emails that have come in if you want to
Okay.
go ahead and get to those.
Do you want to just read the question from the emails? Okay.
Yeah. The first question is asking if you do telecounseling for clients in rural areas. It seems the hardware needs would be less than for telemedicine, and what kind of hardware would you need if you utilize that service?
So if you only did the counseling and maybe not the medicine
Then you would
part?
not need the peripherals. You would not need the scopes, the ENT scope, the derm scope, and the stethoscope. You would just need, and this is what we're going to be using for our substance abuse and mental health IOP. It would just be the video screen and a microphone. And yes, we do utilize that.
We as well.
Okay. There's a couple questions here regarding reimbursement from insurance
we didn't talk
companies.
about that.
That's
I will
great.
stay away from reimbursements.
I can talk a little bit about reimbursement.
Yeah, we can talk a little bit about that. Medicaid reimburses the same as an in-person visit at this point. It's been coded to where it reimburses for telemedicine. Private insurance has been a little more slow to follow, and the hope is that Blue Cross Blue Shield and other private insurers will also follow and will have the same reimbursement rate as Medicaid.
And that was a concern for us because without that reimbursement rate, then you're not being able to be self-sustaining
Right.
once the equipment is paid for and to sustain and help with the cost of the provider. But as you said, Medicaid in Alabama has approved it, and we're hoping that everyone else is going to follow.
So that's going to be a state-by-state thing that you would encounter. It may be different in other states. Some states, their Medicaid program may have not any, but they might not have any written codes about it. So once that state had a telemedicine program, they would have to go back and write the code. But in Alabama, it was originally just dermatology, maybe through telemedicine, and something else, and now they do the telemedicine for HIV and AIDS care also,
And psychiatry.
in psychiatry. That was the other one that they also did.
Okay. How about interactions with clients? Are all of them live, or do you use the store and forward capability of the telemedicine equipment?
We do not use store and forward. We do real-time live audiovisuals. This is also important because I can speak about medical care, wherein medical care has to be on time, it has to be real time. So we have not been using store and forward.
I would think that the store and forward would also be trouble with the reimbursement. I think that would need to be part of that live medical visit. Now, there is some capabilities for the information that you're gathering to be put into the EMR, which the stethoscope readings and that
Right.
kind of thing
The phone
goes
card
straight into the electronic medical record.
Okay. And our last question at the moment is asking if you have also used the telemedicine equipment for education with a group of clients, or do you only utilize it for one-on-one encounters?
This is a wonderful question, Christy. The question was that do we use telemedicine equipment for group sessions versus one-on-one only? Telemedicine's limits do not include the group counseling. In fact, we were talking, Dr. Thomas and I were talking, and she had this wonderful idea about how prenatal care could be grouped into a one visit. Absolutely, yes. It could be used. So far, we are not using that. We are not using the group counseling. We are not using the group sessions also, but there is no reason for anybody to not do it. And we are actually planning on that one, in that especially nutrition education classes, smoking cessation classes, and diabetes education classes, and such education classes especially will be group sessions, and they will happen at MAO.
And AAC will be in increasing our care through the IOP, which will be group sessions. One thing that we are doing is that we're installing microphones that will come down from the ceiling to better enable everyone in the room to be able to be heard on the microphone. So I think with some small modifications that group counseling is definitely a possibility, and we're going to start doing it in September.
Great. We have no more email questions or no phone calls at the moment, but I certainly encourage folks out there, if you're still watching and have a question, to take advantage of the time that we do have left here to send us your questions. So.
I have a question for Sandy. You know, you have to shut me up, otherwise I will not stop.
You just keep right on going.
Sandy, where do you think this telemedicine is going?
As I said earlier, what I hope for this program is that we can eventually put a telemedicine suite in each and every county health department in the state of Alabama, and for other states as well. They could probably use this as a model. Once we get a telemedicine suite, it doesn't have to be reserved for just HIV care. Any specialist that is lacking, like I told you about the health professional shortage areas in Alabama, any specialist that is not in that area can then, with telemedicine, go into their clinic and see a patient in any one of the counties in Alabama. And I believe some of the counties have more than one health department site, so that would it would put care right in everyone's neighborhood. So what this has done for MAO, as you know, you can see your patients in person in our clinic, and then they can walk right next door into the telemedicine suite and see a counselor.
Absolutely.
So instead of us sending people all over the place, and especially these people who don't have transportation, they come in once and they get everything they need in one location.
Appropriately.
And Sandy, one of the statistics that you showed earlier on one of the screens was that there were only 57 ID physicians in the whole state. And we were kind of calculating in our heads, I think only 10 of those are actually doing HIV care. This way, if we had access to telemedicine up in North Alabama, we can connect down to talk to Dr. Bott anytime that we want to. And you also note, if everyone noticed on the map, it looked like we had just not really gone into Mobile, but I think that there's a real growth area down in the Mobile region, the southwest region of the state. So I also wanted to talk just a little bit about MAO and the AIDS Action Coalition are working with the Department of Nursing at UAB with an NIH grant. And this is to do rural mental health with HIV positive women. And so again, we're doing all kinds of collaborations and branching out in different forms throughout the whole state.
Okay.
Yes, Brenda.
Do you think, or what do you envision as the impact of affordable health care on the industry?
We could have gone all day without talking about affordable health care. You know, there are so many unknowns about affordable health care, but, you know, HIV care is in the Cascade as far as being essential health care benefits. And I think that this will only increase our ability to see more patients. Don't you think, Dr. Batt?
Absolutely, yes, I feel so, yes. And,
Again, normalizing HIV care in the doctor visit, and but if we can get our resources out there and be able to help more people in the community, that's what we need to do.
You've got a couple more questions that have come in.
Okay, sure.
Okay. The first one is asking if you can review again the role of the in-person nurse and talk about their interaction both during the teleclinical visit and afterwards with the physician.
I think that's
absolutely. I personally have been blessed with a wonderful, wonderful nurse in my spoke sites. The nurse visit is very vital in telemedicine. It is similar to what it would be if it were to be in-person visit. But the nurse will actually talk to the patient and get me the data and follow up with the patient. She will be present during the telemedicine visit. So she will actually sometimes will work as my hands on the distant site, be it 100 miles away. For example, if there is an abscess or something like that on a patient's body that needs to be evaluated. For example, if there is a need for the range of motion to be tested. I don't use it exclusively or extensively, but in certain times where there was a need, when it has come up as an ancillary question, we have utilized. Plus, we do need the nursing staff to auscultate the patient so that I can hear the patient. Do the ENT scope, use the ENT scope or dermoscope, and such things. Well, I believe in the state of Alabama, those duties have to be executed for a telemedicine encounter, have to be executed by an RN, I believe. But if the laws were to change, we can utilize other people who are trained in nursing also.
Okay. Very good. All right. Next question. In building a budget proposal for your telemedicine application, what does a telemedicine suite in one of the health departments cost? Are there any matching funds that were sought? And if you could elaborate at all on that, this person would be grateful.
I can probably speak to that. So the equipment itself, I think Dr. Batt talked about $10,000 per site. So that would be double because you need, one on each end. Then the scopes are about $500 a piece. But the big reoccurring cost is the cost of the T1 between the two sites. Which for us in Huntsville, 1.5 or 3 meg, I act like I know what I'm talking about, I really don't, is about I believe I just signed a contract for $568 a month. Then we have the cost of the nurse, and we also, and so the space and that kind of thing. Where we went for our matching funds, again, we went to in Huntsville, we have a lot of technology companies that like to be helpful in the community. So we went to Boeing and some of our technology firms and banks, different foundations in Huntsville. And again, they have been responsive to it.
Okay. Anybody else? No? Okay.
But I think those are the only reoccurring costs. Mike, are you?
I think you're on target.
Okay.
Okay. Another question? Okay. Do you work with other facilities around the country to see clients outside of your service area?
Not yet.
Not yet. I should say the question was that do we see clients outside of our agency or clinic? So far we have not because of the sheer logistics of that one. But like I said, if all HIV care clinics in the state were to come together, we could create a wonderful telemedicine network wherein it will be a patient-centered medical home so that any patient could be seen in any place and we will be sharing. See, we have to remember that success is by collaboration. Success is by collaboration. So I hope that day comes soon.
Very good. At this time, there are no more questions.
Okay.
Doctor,
You mentioned the portable unit. Could you expound on that a little bit?
Sorry, repeat it,
The
please.
portable unit.
Portable unit.
Yes. So in the Polycom units that we use, one is called, actually we use 3 different kinds. One is called the Polycom HDX 4500, which is a portable thing which comes in a cart. The other one is called Polycom HDX 7000, which is right now which is mounted on the wall. And we also use what is called as the Polycom provider cart. So the portable cart will actually let us drag the telemedicine equipment with the video, with the audio sensor, with the peripherals to the patient's room. But it has to have the internet connectivity. But there have been some thoughts about utilizing LTE connection to make that happen. I have seen some prototypes of real portable, real small, tiny food box sized telemedicine units which are portable, which can actually be taken to the patient's house.
Yes,
and
yes.
connect to the 4G LTE. And it's not available in Alabama yet,
Yeah.
but some tremendous progress has been going on there.
Robin, our Polycom representative, has talked to me about how it is being taken into the home for like home health care and that kind of thing. And it is completely portable, but not here.
Yes.
Well, that concludes our presentation, and if you think of any questions after the presentation, all of the panelists and our contact information at Southern AIDS Coalition is available in the slides. As a reminder, the handouts for the presentation are available on the Southern AIDS Coalition website and the ADPH website. This program was recorded and also will be available on both websites within 2 business days. SAC greatly appreciates the time, information, and thoughtful presentation from Sandra, Dr. Batt, and Mary Elizabeth, and we thank you, our participants. Following this program, you will receive a short survey via email. If you could please take a couple of minutes to fill it out, it will help us to improve future presentations. Thank you for your time, and have a great day.